Good morning for those of you who are in the morning time zone. My name is Ron Blankstein on behalf of the SCCT and my co-moderator, Dr. Kuhn Niemann. It's my pleasure to kick off this webinar. This is the first of two webinars that the SCCT will be having about the new chest pain guideline. And today we are going to talk about acute chest pain. Now, yesterday, if anyone was following social media, they know that there was a big announcement made. It was anticipated a very big announcement would be made. Of course, I think everybody all over the world was waiting for this announcement. And finally, the announcement came, the new name of Facebook. But of course, for many of us in the medical community, this is not the announcement we were waiting for. We were waiting for the new chest pain guideline, which did come out yesterday, same day. And I want to start by thanking the chairs of the guideline, particularly Dr. Martha Galati, who's also the social media moderator for today's event and will be a speaker on the webinar 1 week from today. I also want to thank all the authors and members of the writing committee. Many of them are speakers today. I want to thank the many reviewers. There's over 60 reviewers who participated in this in multiple other partner societies who worked so hard, both their members and their staff members, to bring this to fruition. So enormous gratitude to the countless of individuals who worked on this. So today, again, we are going to be talking about the management of acute chest pain. I think many of you have seen the agenda, so I will not belabor it. I will actually go straight to introduce the very first speaker today, and that's Dr. Dave Morrow. Dr. Morrow does not need a lot of introduction. He's a professor of medicine at Harvard Medical School. He's a senior TIMI investigator, one of the international experts in the use of biomarkers for acute chest pain, a member of the guideline writing group. And I will turn it over to him to talk about how we evaluate acute chest pain.
Thanks very much, Ron, for inviting me to
Dave,
join.
I'll ask you to turn on your camera.
There we go.
Perfect.
Sorry, when it flipped over. So thank you very much for inviting me to join this truly exceptional faculty. I'm charged with giving a 10-minute overview of what is new in the 2021 chest pain guidelines with a focus on the assessment of acute chest pain. And so at the start, it's worth emphasizing that this guideline is unique in that it builds on multiple prior guidelines, but rather than being focused on a specific disease or syndrome, it's framed around a presenting symptom and one that dominates much of our clinical practice, and that's the evaluation and diagnosis of chest pain. And so there's a lot that is new in the 2021 chest pain guideline, and these are very nicely encapsulated by 10 top take-home messages that you can remember by the mnemonic chest pains. But in my 10 minutes, I'm going to focus on 5 of these that are particularly new and important. The H, high sensitivity troponins are preferred. S, share the decision-making. T, testing is not routinely needed for low-risk patients. P, for pathways that I'll spend some time on in the next 10 minutes. And then lastly, that N, non-cardiac is in as a description of chest pain, whereas atypical is out. And I'll highlight throughout this presentation in red, as you see in the text on this slide. I'll put those elements that are particularly new, and you'll also see a red border around some of the guidelines that I'll show you for that same purpose. So first, for the description of chest pain, this is the first guideline to recommend against using the term atypical to describe chest pain. And we all know that chest pain can present in any location in the upper thorax. We also recognize that diaphoresis and shortness of breath can be equivalents. And chest pain shouldn't be described as atypical because that's really not helpful in determining the cause, and importantly, may be misinterpreted as being benign in nature. So what we recommend is that chest pain should be described as either cardiac, possibly cardiac, or non-cardiac, because these terms are more specific to the potential underlying diagnosis that you are surmising. Next, while previous guidelines have certainly recognized differences, important differences in the presentation and diagnosis of chest pain in women and older patients, the 2021 chest pain guidelines pay particular attention to patient-focused considerations and across each of these populations, but also including the ethnically diverse, for which there are 2 Class 1 guidelines. The first is cultural competency training, and the second is use of formal translation services are recommended as a Class 1 guideline. Now I want to come to really what is the most important theme, I think, of the chest pain guideline, and that is that testing is not routinely needed for low-risk patients. And this theme is embodied in the central flow diagram evaluating patients with acute chest pain, among whom we start with a history and physical exam. ECG and chest X-ray are Class 1 guidelines. But then among those who have an obvious non-cardiac cause, no cardiac testing is required. This is a Class 1 guideline. Among those patients with possible acute coronary syndrome, they undergo further risk stratification, which I'm going to describe. But those who stratify to low risk, importantly, no additional testing is required, and that as well as a Class 1 guideline. High-risk patients proceed to invasive coronary angiography, consistent with previous guidelines, and then the majority of decision-making regarding additional diagnostics is in this intermediate group, and you're going to hear much more from the subsequent faculty in that regard. And so now central to the guideline and what I want to walk you through is the further risk assessment to achieve and identify that particular group. So first, turning to the cardiac biomarkers, just as in previous ACS guidelines, we recommend use of troponin. It should be done serially to identify a rising and/or falling pattern. But what's new is that high sensitivity troponin is now recommended at the Class 1 level as the preferred biomarker. And in addition, as a Class 1 recommendation, elevating it from the text of previous guidelines is that clinicians should be familiar with the analytical performance and the specific cut points for whatever assay you're using at your institution. And so another important new element of the 2021 chest pain guideline is a framework for considering diagnostic testing that involves 3 key assessments. First is the initial assessment of the probability of myocardial ischemia that I just spoke to. Second is a prior history of coronary artery disease. And then third, among those with no known coronary artery disease, their prior testing for CAD. And so you're going to hear much more detail about how these drive you to specific testing algorithms among these branch points from the subsequent faculty. But my second charge is to talk about how do you risk stratify this intermediate group and how do you distinguish them from those patients that may be at lower risk. And so with that, I want to come back to the P of chest pains to emphasize what is new in the guideline and also give you some additional recommendations regarding the use of cardiac troponin. So first, clinical decision pathways, or CDPs, should categorize patients into low, intermediate, and high risk to facilitate their disposition. Secondly, in addition to those, you use cardiac troponin, and specifically our timelines for measurement have moved up from 3 to 6 hours for conventional troponin, and that may still be what you're using at your center. But for those who are using high sensitivity troponin I or T, that time interval moves up to 1 to 3 hours after presentation. In addition, for those patients with a normal EKG and symptoms that began at least 3 hours before ED arrival, you have the ability to reasonably exclude myocardial injury with a single troponin value that's below the limit of detection, and that's a Class 2A recommendation, a so-called one and done strategy. And then lastly, as you put those 2 things together, the CDPs and your assay, it's important that institutions who implement a CDP should do so with one that incorporates their particular troponin assay. So know your CDP, know your assay, and make everyone at your institution familiar. So there are 5 CDPs that are discussed in the guidelines, and that may be selected based on your institutional preferences. Each one integrates elements of the history, in most cases the ECG, and then also cardiac troponin testing to arrive at a stratification of risk between those that are low, intermediate, and high risk. Low risk in particular identifies those patients where there are absent clinical risk indicators, so that accumulates in a low score, in addition to negative serial testing below a low risk threshold or below the limit of detection. And each of these are detailed in the guideline to help you at your institution. So though I've already emphasized this point, I do want to come back to the statement that our guideline committee determined that there was no robust evidence that stress testing or cardiac imaging within 30 days of an index ED visit improves outcomes. And for that reason, there was a discrete change from previous guidelines where stress testing within 72 hours was broadly recommended to the adage that further testing is not routinely necessary for those patients who are low risk. So finally, in closing 2 slides, I just want to highlight 2 additional items that are new in the 2021 guideline. The first are recommendations for shared decision-making, that those patients who are low risk by a CDP, patient decision aids should be used to facilitate risk communication. Secondly, in those who fall into an intermediate risk group, shared decision-making is recommended to improve patient understanding and also reduce low-value testing. So lastly, the chest pain guideline takes a much broader view than previous guidelines that have touched on acute coronary syndromes or aortic syndromes in particular, to include all of the life-threatening cardiovascular causes of chest pain, including acute aortic syndrome, pulmonary embolism, acute myocarditis and pericarditis, and acute valvular heart disease. So I'll leave you with this central mnemonic, chest pains, and remind you that each of these that is marked with a click on this, a checkbox on this slide of the 2021 guidelines for evaluation of diagnosis and of chest pain are new, and hopefully all of you will find them useful for your practice. So I thank you very much for your attention.
That was wonderful, Dave. Thank you very much for going through the essentials of the guidelines and highlighting some of the most important changes that we've seen. So as we transition to the next speaker, I'd like to introduce Maros Ferencic. He's section head of cardiovascular imaging at Oregon Health Science University, and he will be diving deeper into the role of coronary CTA in the new guidelines.
Thank you, Kun, for the introduction, and I will pick up where Dr. Morrow stopped and talk more about coronary CTA and its role in new guidelines. As Dr. Morrow already alluded to, clinical decision pathways have a critical role in determining the risk of the patient. And as we talked about it, low-risk patients really have class 1 indication for no further testing and then discharge from the emergency department. As we already reviewed this, these are patients that have 30-day risk of MACE less than 1%. And as opposed to prior guidelines, these do not really require further testing. This should be, of course, decided in shared decision-making. And the guideline does emphasize the need for outpatient workup of these patients, referral for outpatient workup. Specifically, outpatient calcium score scanning can provide additional information for long-term risk stratification. And here is some particular low of cardiac CT in further evaluation of these patients. As we discussed, high-risk patients have class 1 indication for invasive coronary angiography, and these particular guidelines do not provide further evidence for use of CT in this group at this point. In the rest of my talk, I will focus on the intermediate risk patient in whom further diagnostic testing may be indicated. As alluded to, there are 2 main groups of patients that we will talk about. There are intermediate risk patients with no known prior coronary disease. In this group, there are, again, two subgroups. One is patients who already did not have any prior testing. So those are patients who never had a cardiac test. And then there's a group of patients that had prior cardiac tests. Let me walk you through this diagram in figure 9 for patients that had no prior cardiac testing and have no known coronary artery disease. In those patients, the guideline provides class 1 indications for coronary CTA and for stress testing. More specifically, there is class 1 indication, level of evidence A, indications for coronary CTA as a tool that is useful for exclusion of coronary atherosclerosis and obstructive coronary artery disease. There is class 1, level of evidence B, NR, meaning non-randomized, for stress testing. This includes exercise ECG, stress cardiac MR, stress echocardiography, and stress PET and SPECT. The test is useful for evaluating and diagnosing of myocardial ischemia. Now, if you decide to perform coronary CTA based on this guideline, the guideline further guides you as to what to do with the results. In patients that we find non-obstructive coronary artery disease, meaning less than 50% stenosis of any of the epicardial coronary arteries, these patients can be discharged from the ED. However, there is a very important new component. Now, once the plaque is detected, less than 50% stenosis, these patients are now diagnosed with coronary artery disease. For the future reference, these patients will have known coronary artery disease, and it's true for all anatomic testing, whether it's invasive coronary angiography or coronary CTA. The guideline emphasizes the need for outpatient follow-up, and guideline-directed medical therapies is in this patient group. In patients that have obstructive coronary disease and high-risk features or frequent angina, these patients have class 1 indication for invasive coronary angiography. The high-risk coronary artery disease features are defined in this guideline as left main stenosis more than 50% stenosis, or anatomically significant 3-vessel disease, meaning more than 70% stenosis in epicardial coronary arteries. The intermediate group in this represent patients that have obstructive CAD, meaning more than 50% stenosis in any epicardial vessel, or the stenosis is inconclusive, cannot be definitely evaluated in coronary CTA. In this patient population, there needs to be, again, shared decision-making. Some of these patients can be treated medically with guideline-directed medical therapy. In patients that opt in shared medical decision-making can be further evaluated either with FFR-CT or stress testing, which both have class 2A indication for further evaluation. Depending on the result of this testing, again, if there is severe ischemia or moderate ischemia, invasive coronary angiography can be appropriate, or if there is not moderate or severe ischemia by FFR-CT or stress testing, the guideline-directed medical therapy and discharge are appropriate. The next subgroup, as I mentioned, is patient with prior testing, again, no known coronary artery disease in the past. If the prior testing was performed, the guidelines provide following recommendations. If there was a recent negative test and the patient ruled out by high sensitivity or traditional troponin and does not have significant EKG changes, these patients can be discharged from the emergency department. The guideline specifically adds what's called warranty period, time from the prior negative test. For invasive coronary angiography and coronary CTA, this is 2 years. So if you had a CTA within 2 years and this was negative, you don't need additional testing. For stress testing, the warranty period is 1 year. There's another role for coronary CTA in the subgroup of patients. Again, this is patients that have no known coronary disease but have had prior testing within the last 1 or 2 years. Specifically, if they had inconclusive or mildly abnormal stress test within the last year, those patients have class 2A indication for performance of coronary CTA. The further management after coronary CTA is similar as in the previous group, so I won't go through it. In the next part of the talk, I will talk about intermediate risk patients that have known coronary disease. Again, these are patients that were already diagnosed with CAD. What's important in this group is that traditionally we saw these as patients with either obstructive CAD, prior interventions, or ischemia on prior testing. This guideline specifically emphasizes that patients with non-obstructive disease, those that's with less than 50% stenosis on prior anatomic testing, are included in those with known coronary artery disease. Even more, it goes further and includes patients that have, for instance, coronary calcium on calcium score, or even on prior chest CT. These are all patients that have now known coronary artery disease. In this group, there are two sort of options. The first option is to defer further testing and intensify guideline-directed medical therapy, and that has class 1 indication. However, if you again share decision-making, decide for further testing, you are guided by the prior results. If they're obstructive coronary artery disease and patients have either high-risk CAD as defined previously, left main or 3-vessel disease, or they have now frequent angina, the invasive coronary angiography has class 1 indication for further evaluation. Patients that have non-obstructive coronary disease on prior testing, less than 50% stenosis, coronary CTA has class 2A indication, level of evidence B and R, non-randomized, for further CTA evaluation. And this is helpful to determine progression of atherosclerotic plaque and progression into obstructive coronary artery disease. Stress testing has sort of two potential indications. It can be used in patients with non-obstructive CAD in the past, less than 50%, but also for patients that have obstructive more than 50% stenosis. And this is again class 2A indication, level of evidence B and R, non-randomized, and it is for the patients who have new onset or worsening of the symptoms. I would emphasize that for this group, it is recommended to do stress imaging tests, so PET, SPECT, CMR, or stress echocardiography. The exercise ECG is not included in this group. Further management after the result of CTA is again very similar to our first slide, so I will not go through it. So with this, I would like to conclude my talk. This is the summary of all the recommendations for main recommendation for coronary CTA in patients with acute chest pain. Thank you for your attention. I look forward for the discussion.
Thank you very much, Marosh. Fantastic talk, distilling a lot of information. I'm next going to turn it over to Dr. Andrew Choi, who's an associate professor of medicine and radiology and the co-director of cardiac CT and MRI at the George Washington University School of Medicine. And Andrew's task is also a challenging one, which is what do the guidelines tell us about how to select between different testing options? Dr. Choi.
All right, as a reviewer, congratulations to Dr. Galati and the Guidelines Committee for this tremendous document. Let's get right into it. And so as Dr. Morrow and Ferencik have outlined, there are options for those patients that are at intermediate risk with acute chest pain. And the first thing for a clinician to do is to determine whether there's no known CAD with prior testing versus having known CAD. And so on the left, as Dr. Ferencik has outlined, is figure 9, the evaluation algorithm for patients with suspected ACS at intermediate risk with no known CAD. And on the right is figure 10 from the guideline, the evaluation algorithm for patients with suspected ACS at intermediate risk with known CAD. I'd like to bring your attention to these starred areas, in particular this blue star. If we zoom in and we think of our patient that has acute chest pain at intermediate risk with no known CAD and no prior testing, the guideline has outlined a class 1 indication for both stress testing and CT angiography, and that raises the question for the clinician is how to choose among the various imaging tests. And so the guideline outlines that testing choice will be influenced by site expertise and availability, but knowledge regarding which test may be preferable is useful when selecting between the different modalities. And so this is figure 6 from the guideline that are factors that favor CTA versus stress imaging in choosing the right diagnostic test that is provided to us by the guideline. Let's take a minute or two to walk through this. On the right of the table and figure are those factors that favor the use of stress imaging. If one's goal is to be ischemia guided in the management, for example, with a higher pretest probability of CAD or even known CAD, then that may favor stress testing. having high quality imaging and expert interpretation routinely available. As a general cut point, an older age patient over 65, having a prior CTA that's inconclusive, and when thinking about different stress testing modalities themselves, as shown in the yellow box, the stress test choice may be guided by the patient's exercise capacity to do an exercise stress test, rest EKG abnormalities to be able to interpret that, and then importantly, in comparison to evaluating for exercise capacity, the desires to evaluate for coronary flow as can be done by PET or quantitative stress perfusion CMR, or LV scar as can be done by CMR with delayed enhancement that may factor towards favoring stress testing. Now on the left of this table and figure are those factors that favor the use of CTA. And so if the goal is to rule out with high sensitivity and negative predictive value obstructive CAD, CTA may be your favorite approach. In addition, the CTA offers the unique ability to evaluate for non-obstructive CAD, as Dr. Ferencik has outlined. In addition to having high quality imaging and expert interpretation, CTA is favored for those patients that are at perhaps lower pretest probability and at younger age, 65, having a prior functional study that's inconclusive, as well as uniquely, as Dr. Morrow mentioned in his last slide, if there are other compelling indications for the patient's chest pain, such as evaluating for an anomalous coronary artery or evaluating the aorta or pulmonary artery for a dissection or pulmonary embolism, then in a focused and appropriate patient, a CTA may be helpful there. As we show in the lower left in this blue box with an example of plaque here, as Dr. Ferencik outlined, CTA offers the opportunity to diagnose the extent of plaque, to evaluate for vessel-specific ischemia through FFRCT, as well as guiding subsequent decisions on goal-directed medical therapy and invasive angiography. And then importantly, as the guideline outlines, CTA contributes to a reduced time to diagnosis and prompt safe discharge, as has been shown in multiple randomized trials. Now, in addition to these clinical factors, in Table 5 of the guideline, it outlines choosing the right diagnostic test and assessing for potential contraindications. And while we won't be able to go through each modality here, what the guideline outlines is that our readers and clinicians should review each imaging society's guidelines for more details on test contraindications, that screening for pregnancy should be performed according to local imaging facility policies, and that for all testing modalities, the inability to achieve high quality images should be part of the consideration, and in particular for obese patients. And so to summarize, particularly for cardiac CT, what is the ideal patient for CT as first line in acute chest pain by the 2021 guidelines? Well, it's favored for younger patients, and that's as a relative consideration at 65. Having an intermediate pretest probability, as Dr. Morrow outlined, like using a HARD score or EDACS score. Having a prior functional study that's inconclusive. Uniquely having the ability to evaluate for coronary disease, evaluate for plaque, and estimate vessel-specific ischemia. The absence of contraindications such as a low GFR or a contrast allergy, and I think most importantly, the ability to have high quality imaging and interpretation available, and to utilize the ability for rapid diagnosis and safe discharge. Thank you for your time.
Thank you, Andrew, for that presentation. I think it's important to highlight, how important it is to consider all these different factors, not a black and white thing or one test for all, and all of these things are hugely important. So thanks for that. So while we transition slides to the next presentation, it's a pleasure to introduce Leslie Shaw. She has played a major role. If we can unshare, yeah, thank you. She has played a major role in the writing of these guidelines, but also contributed hugely to the gathering of scientific data that formed the foundation of these guidelines. So it's my pleasure for her to tell us a little bit about what is still missing, because as there is no conclusive evidence ever in medicine, what are the things that will guide the next guidelines? Please go ahead, Leslie.
Like an easy job. It's always easy to sit in the back seat and poke criticisms at what isn't in the guideline. And so I'm just going to highlight perhaps some questions that you may have as you start to implement these guidelines and where they are in terms of helping you with guiding your patient. Sorry, I'm trying to struggle with it. It's not responding. Here we go. And so a couple of questions I thought you might be asking. Will CTA actually improve my patient's event-free survival or survival? And can I use CTA in higher risk ACS? And what is the guideline? What do the guidelines say and do not say about the higher risk ACS patients? I think more fundamentally for where we are in terms of the evidence is the big glaring evidence gaps is how do I treat my patients based on CTA findings? Developing strategies of when do I repeat test potentially, or just whole CT guided strategies of care. How do they unfold? What do I expect next to ensue in terms of patient testing and treatment? And I think what to do with the patient after discharge from the emergency department is key in terms of elements that we actually have to have in terms of particularly around preventive care, anti-anginal therapies, and I think especially for that large patient population for whom your labs identify non-obstructive disease. Now, first of all, Dr. Choi mentioned this. There are 11 randomized trials which are integrated into the guideline, but there are 2 newer trials that are not. And so the evidence in terms of higher risk ACS patients, we see both the verdict trial, which was published in 2020 in JACC, and we see very recently a randomized trial from David Newby's group that was published in the British Medical Journal. These 2 newer trials are largely in higher risk patient populations. The verdict trial, non-ST elevation ACS, patients with acute infarction, those with dynamic ECG changes, or those with an elevated GRACE score. What the evidence shows, consistent with the prior evidence from those 11 randomized trials, is that CTA performed early within 12 hours is associated with a high negative predictive value, over 90%, which results in a strategy of very accurate diagnosis, prompt diagnosis, and prompt discharge. Now, the recent trial from David Newby's group, also in a patient population with higher risk, those patients with known coronary disease, cardiac troponin, or an abnormal ECG, very early CTA within 4 hours of presenting to the emergency department, did not improve outcomes. That is in terms of death or myocardial infarction at 1 year. So the important message is consistent with the current randomized trial evidence, although the newer evidence is in slightly higher risk patient populations. Now, overall, CT lacks a lot of guidance in terms of developing strategies of care. That's both in the acute setting as well as in stable chest pain. The timing of treatment. How do you track the adequacy of care? That's not to say we don't have absent any of this evidence, but a lot of it's based upon expert opinion. And certainly we would like to have more randomized trial evidence on guiding preventive therapy. Are we going to have the same preventive therapy for that patient who has a large burden of non-calcified plaque, positively remodeled artery, as compared to that patient that has a lot of calcified plaque? It's hard to know until we see the randomized trials. What about anti-anginal therapies? Are we going to treat patients differently based upon the composition and the size and the burden of plaque? And will we see other additional important clinical outcomes? Will a CTA-guided strategy be better able to elicit better angina control as compared to an ischemia-guided therapy? These are all the questions I think you probably are going to be asking yourself as you review the guidelines and as you implement them into your own clinical practice. I think the last point, though, I think to make is what to do with the patient with non-obstructive disease. This is one I think all of you listening on this SCCT webinar have this focus probably on atherosclerosis, but there's similarly a large group of folks that are focusing in this patient with non-obstructive disease. Should I be working up this patient under consideration of having coronary microvascular dysfunction? So these questions remain as to what to do with these patients in terms of testing. What about treating? Should we treat these patients with angina? Should we treat these patients to secondary prevention goals? What about follow-up testing? I think particularly in the patient who has high-risk plaque features. Again, that same patient with a lot of non-calcified plaque, positively remodeled artery. These are known precursors for acute coronary syndromes. You know, should we be following these up patients with routine testing, and then when? So lots of questions, and I look forward to all of the interactions and trying to improve the quality of care for testing of patients with presenting with acute chest pain. Thank you so much, and I look forward to the discussion.
Thank you, Leslie. What an amazing talk. You're always inspiring us to think about the next steps, and you have done that yet again here. So next, we're going to go through a case presentation, and I'm going to turn it to a good friend and colleague, Dr. Renee Bullock-Palmer, who also served as a co-author of the guidelines. She is the Director of Non-Invasive Cardiac Imaging and Women's Heart Center at the Deborah Heart and Lung Center. And Renee will walk us through a case of acute chest pain, and then we'll turn to the panel and we're going to discuss the case. And after that, we're going to open it up to the Q&A. I see already a lot of great questions in the chat, so thank you all for that. So Renee, on to you.
Great, thank you, Lon. Hello and good afternoon, everyone. I'd just like to thank SCCT for the invitation to be a part of this great webinar. So I'll be presenting a case of acute chest pain and walking through how the use of the chest pain guidelines can assist with clinical decisions in managing these patients. I have no disclosures. So the case is that of a 67-year-old male patient with no past medical history. However, he had a family history of his father having acute myocardial infarction at 54 years of age. He presented to the emergency room with a history of non-exertional pressure-like chest pain that was had been occurring over the past 3 days. His blood pressure was unremarkable, as well as his heart rate. His heart rate was 63 beats per minute. His BMI was 23, and his cardiac exam was unremarkable. His EKG showed no ischemic changes and showed normal sinus rhythm at 6 to 8 beats per minute. His troponin I level at time 0 was less than 0.03, and his chest X-ray was unremarkable. His point of care echo was performed, which showed a left ventricular ejection fraction being normal at 60%, with no regional wall motion abnormalities, no valvular heart disease, and no pericardial effusion. So what would be your next step? So here's how the recent chest pain guidelines can assist us. So one of the key areas in the chest pain guidelines for the assessment of acute chest pain is the use of the clinical decision pathways. And there's a class 1 recommendation for the use of these pathways to categorize patients into low, intermediate, or high risk strata to assist in clinical decisions in their management. So in our particular patient, for this patient who had no known coronary artery disease, no previous testing, he was 67 years of age with a moderate suspicion for acute coronary syndrome. His heart score was calculated to be 4, which is intermediate. So in figure 8 of the acute chest pain guidelines, the assessment of acute chest pain for patients with an intermediate risk score, further diagnostic testing may be indicated, and especially for index diagnostic testing in patients without a history of CAD. And this also patient had no previous testing. So in this particular chart in figure 8, we're seeing that there's a choice between stress testing or coronary CT, both of which had class 1 recommendation for the use of in these patients with acute chest pain. So at this point, I will turn things over to our panelists to see what would be their next step.
Well, thank you, Renee. I think a good case for discussion. I think a case that probably a lot of us encounter. I'll ask our panelists to join, and I'll turn it first to Andrew as a multimodality imager. How would you think about selecting between the different testing options in the case that Renee just showed?
Yeah, it's a great case from Dr. Palmer. We have an intermediate risk patient, 67 years old, and also with an early family history that can presumably exercise. The beauty of this guideline is that there are multiple options that can be utilized for this patient. You may consider that early family history, wanting to evaluate for both obstructive and non-obstructive plaque. At the same time, the patient can exercise, and so a stress test or even maybe a reasonable option as well. You may also consider what's the shared decision making, what's the clinician, and what does the patient want, and it's a desire to be able to have rapid testing and rapid discharge available. I think the last point to make is that age is a relative cutoff in this guideline. And so even though the patient was 67, I think a CTA is still a reasonable approach as well as a stress test. I might ask you, Dr. Blankstein, to comment further on the age cutoff and how clinicians should think about that.
Yeah, no, I think you are exactly right that the age is a relative factor. I wouldn't even think of it as a cutoff. There's certainly, we all know that there's patients who are under 65 in whom CT is not going to be the best test. It's going to be a functional test or a stress test. And there's patients over the age of 65 in whom CTA may be a very reasonable choice. And folks ask why is that? And I think the concern is, when we have individuals who are older in their 70s and their 80s, they may have a lot of coronary calcifications, and that's going to make the CT more challenging to interpret. But this is just one factor. And importantly, this is not an indication in the guideline. These are comments that the guideline authors put that may help individuals select, but you have to look at the total picture. You have to look at the various factors. And there's several sections of the guidelines that provide more guidance on how to select between different tests. So I know there's a lot of focus on the age, but that's not an absolute threshold. I'll turn it over to Leslie, actually, to see if she has any other comments on the age, because there's a lot of comments on this in the chat.
No, I think it's just what question are you trying to answer with your given patient? And if that question is, do you have coronary disease? Then I think you have your answer. Then an anatomic approach is what you're looking for. If you're worried about angina, you're worried about provocative symptoms, you're worried about what goes on during their activities of daily living, you're worried about ischemia and ischemia-related guidance, and I think you also have your question. I think that taking everything into totality, I think the age was just meant to give people a guidance, and particularly to hit at CT strength on ruling out coronary disease, whereas stress testing it also has issues with regards to ruling out. And I think that's been mentioned in the chat a few times. And I think that's just another strength of CT.
Great. I'll turn it over to Koen for the next question.
Well, I think maybe just one comment about the age is also, I think it's the probability of expecting extensive coronary artery disease, and one important aspect is also the gender, and I think those age directions are also they're probably very different for depending on what the gender of the patient. So yeah, maybe I think we had a couple of very interesting questions in the discussion. But are we first going to show the continuation of this case?
Actually, we had a question from Maroche before we turn to the continuation related to this case.
Right. Yeah. So yeah, one question that I had was about patients with minimal elevations in troponin. How do you deal with those?
Yeah, I mean, this is an interesting question, and this guideline does not really address the issue of patients that have abnormal troponin, more than 99th percentile. And we probably need further evidence and dissect the evidence, as Dr. Shah already actually alluded it. What I would also say, there is another component that's pertinent to this case, which I would like to allude to, and it's the question which test to choose based on what the skill set and quality of the exams are at each institution. I think it's very important to understand what the patient's preference is, what the question is, ischemia versus coronary atherosclerosis. But another important component is that which test is the best test in your institution? What are the pathways to get to the test? And it's very important, critical in the ED setting. If you have a place where you have a setup for stress echocardiography to be performed within a couple of hours of the order from the ED, and the patients are optimized in the pathway how to get to the stress echo, the stress echo can be the right answer. If you have an ED pathway that allows to get a beta blocker prior to actually getting to the CT scan, you have a high-end CT scanner within the ED and can perform and interpret coronary CTA within an hour or two. That may be the right test for your institution. I think the guideline emphasizes the need for creating pathways not only for risk stratifications, but also pathways of the testing, where based on the preferences and risk stratification and availability and quality of your exams, you can choose the right test for the patient. So you get the quality of exam, the answers that you need to interpret. I think that will be critical for the society, or for all the societies actually involved, to prepare these pathways in each of the institutions and to educate us to get the highest quality of all the exams in the imaging for our patients.
Yeah, well said, Marosh. Let's turn it back to Renee now and tell us what was actually done and walk us through your logic in this case.
Sure. So at this point, we had a shared decision discussion with a patient-centered shared decision discussion. And in view of the fact that he had a family history of premature CAD, and the clinical interest was not just to look for myocardial ischemia, but to also look for non-obstructive CAD, which would help in guiding CAD preventative strategies for this patient. On top of which, the patient did not desire to stay overnight in the hospital. He was worried about a big meeting at work. This was approximately 3:30 in the afternoon. So for these two main decisions, we had decided to proceed with a coronary CT. So we had his coronary CT, and he had normal coronaries, right coronary dominant system, and he was discharged from the emergency room within 3 hours of his presentation with a follow-up with his primary care provider. Very important to note that we had achieved a very low radiation dose with a study of 2.8 millisieverts. So at this point, I will turn things over back to the panel. You're muted, Ron.
Thank you, Renee. Well, let's next, we have a question for Dave. And specifically, Dave, you talked in the guidelines about the new preference of high sensitivity troponins, but we know that they're still not utilized across the country very much. What are some of the key advantages of high sensitivity troponin, and what are some of the potential implications of their use specifically for cardiac imaging?
Yeah, Ron, I'll divide that into two parts. First, the advantages of high sensitivity assays for troponin really stem from the very high level of precision that we can achieve with the high sensitivity assays, which lend additional analytical sensitivity, and that has 3 clinical consequences. The first is that we can detect extremely low levels of cardiac troponin in the blood, and therefore lower decision limits to really have a very high negative predictive value for myocardial injury and thereby acute coronary syndromes. The second is that because of that sensitivity, you are able to move the testing earlier. So I described moving from 1 to 3 hours to 3 to 6 hours for interval for serial testing. So it also speeds the evaluation along. And then the third is using those things together, they integrate very well into the CDPs to allow more rapid and more reliable disposition in the emergency department. Because now most of the major manufacturers in the US do have high sensitivity assays that are available on their platforms, they will slowly replace the conventional assays even being used currently in the labs as they phase out the older test. And then with respect to coalescence with imaging, one is you may reduce the amount of imaging you need to do with a negative biomarker result initially with a very low troponin, but also for those patients in the gray zone with low level elevations, imaging is extremely helpful in helping to further risk stratify and determine the ultimate disposition. And then lastly, in those patients with more marked elevation, but a very low clinical probability of acute coronary ischemia, imaging like MRI, for example, may be very helpful in discriminating those patients who may have an underlying cause like myocarditis that's non-ischemic.
Thank you, Dave. So yeah, one of the things that that is difficult when writing these guidelines, and it's something that I would like to ask maybe Leslie to comment a little bit further on, is the different level of evidence. We've seen a lot of evidence for cardiac CT, and did you find the same type of evidence, and can you share some of the process that goes into the decisions, how you get to the recommendations in the guidelines?
Everyone likes to ask me the tough questions, put me on the spot. I think, it is a challenge when you have so abundant randomized trials with CTA. And what we noticed is what we wanted to focus in on is contemporary evidence to guide contemporary care and contemporary testing. And so we set some rules early on that we tried to apply to all the evidence. And then we looked at the evidence. And I actually wasn't aware of all the number of randomized trials, but now there are 13, but in the guidelines, there are 11 randomized trials. So when you compare that to other modalities that don't have that contemporary evidence, or as an example, how do you take a randomized trial that's published in 2020 and compare it to a randomized trial from 2002? And then be fair. I mean, the first and foremost is to be fair, not only to clinicians, people on this webinar, but to be fair to our patients. We need the best evidence to guide your physician who's taking care of you today. And that was a challenge. And it obviously was a long challenge that we spent a lot of time making sure that we got a balanced approach to this. And when you get a balanced approach, some people are not happy, and that's okay too. But we try to do what's fair. We try to provide evidence and also consider utilization of the modalities as being a core part. And we had a lot of discussions about that. I don't know if Dr. Blankstein wants to add anything to that, but it's not an easy task to compare when you have evidence to a modality that doesn't have evidence.
Yeah, indeed, not an easy task at all. And, Leslie and I and the rest of the committee, we reviewed hundreds of studies in this space, just in the imaging space, hundreds of studies. And we really went by and we did a systematic review of all the available studies. And as the guideline was happening, which took several years, whenever new studies came on, those were incorporated as well. So I think one of the things I have is a lot of respect, not just for this committee, but prior guidelines about the amount of work it takes to go through every study in the literature and grade the level of quality and put it into a construct that allows you to write recommendations. And I think that's one of the key things about a guideline that's different from an appropriate use criteria or an expert consensus statement, is that the vast majority of the recommendations in this guideline are based on data, are based on evidence. Of course, you can look at the level of evidence, what we call the LOE, to see what's the quality of the evidence. There are some cases that some recommendations are expert opinion, that there's no evidence, but the group feels this is a very strong statement to make. And those are going to be designated as EO, as expert opinion. But we actually don't have a lot of those compared to, I think, prior guidelines. So a lot of evidence in this space, a lot to synthesize. Other questions from folks on this? If not, I'll go to some questions that I see in the chat. Other comments from anyone else on this topic of the evidence? A couple kind of practical comments from or questions in the chat. I'll ask Marish about this one. We have a question about the BMI cutoff for cardiac CT. What are some of your recommendations on that?
Yeah, I think this goes back to what I already talked about. It goes to your local experience in your local setup. There are now modern scanners that can easily handle patients with higher BMIs of 40, 45. I can routinely get excellent image quality on these heavy patients with appropriate settings if I have the appropriate scanner. The same is true for coronary artery calcium. I don't think there is any absolute cutoff point. If you have contrast protocol at a MAs and KV setting and scanner that can handle it, that's appropriate. Now, what's critical is that you know what your institution can do. And it's very important that you create it as a leader at your institution, your local pathways. And what's even more important, that your referring physicians and clinicians understand what those pathways are. And it's not only understanding what goes into the scanner or, PET or CT aspect, whatever it is, stress echo, but what comes out of the scanner, that your referring clinicians understand what are the limitations of the test. And there's a lot of work ahead of us to implement the guidelines. We have a beautiful document and really strong endorsement for coronary CTA, but we need to translate this document into the clinical practice.
And I think an important point there, and you said something very important, which is translating this into clinical practice and also pathways. And I think no imaging test sits in itself. It's always part of pathways. And I want to turn to Dave Morrow, who's actually been a leader all over the country, but especially at our center at coming up with pathways. What advice do you have for centers who want to create pathways, not necessarily imaging pathways, but now pathways in the ED to incorporate one of the ADPs that's in the guideline? What's some of the basic advice for an institution that says this is a good idea, we want to start a pathway?
Yeah, I think 3 steps. Know the tools that you're using. So you really need to know your troponin assay, know the analytical cut points, know its analytical performance. You need to know your best, as Maros described very well, know your best tools on the non-invasive and the imaging side as well. And then you need to be collaborative, multidisciplinary. So, for example, on the biomarker side, it really means bringing in our emergency clinicians, our laboratory, our cardiologists, as well as all of the other people that we feed results to make an interpretation. I think the same thing is true with CDPs in the emergency room. Is there are multiple evidence-based CDPs to choose from, and you need to find the one that fits well in a very multidisciplinary way and learn from other centers, to talk to like-minded centers in your health system or other comparable academic hospitals if they've been through it before.
Okay, no, really, really useful and practical advice. I see a question in the chat from Yael Maxwell about whether these guidelines will impact reimbursement. I don't know if anyone wants to take that. If not, I'll give my thoughts.
Go ahead.
Well, I actually don't think guidelines. I don't think guidelines have a direct impact in reimbursement. There's plenty of things that are, class 1 that don't necessarily get the right reimbursement. And we've had a lot of discussions at SCCT with congressional leaders. And frankly, at CMS, at least, the thing that determines payment is not the guidelines. So I think there's obviously it helps because it shows that there's good science. But I think there's this notion out there that because you have a class 1 indication, and this is true for any of the modalities, by the way, that necessarily is the avenue to get payment and reimbursement. And there's so many other factors. So it goes well beyond the guideline, in my opinion, and probably a topic we can discuss more later.
And which will require our continued efforts, I should add, to improve that situation.
Right.
Yeah, I think there was one more question in the chat. Something about the triple rule out is something that comes back in different guidelines. Does anybody want to comment on that? What the position of the guideline is on triple rule out?
Certainly if you use CT, there is in the guideline at least some language. Again, this is not a formal indication, but this is in the language that if you want to evaluate the aorta and the PE or the pulmonary artery for PE, that may favor the use of CT if you're in an institution that has the right protocol. But other than that, there's really not a whole lot of particular indications around that. That's very site specific. Many sites don't do a triple rule out. There's always been a concern that that clinicians should be able to select what's the pathology they want to look for. So it's actually pretty rare to really need a case where you need added radiation and added contrast and do a real triple rule out. So there's no strong stance on that. But if you have that protocol for the right patient, that may favor CT, but nothing absolute about that one.
Yeah. Right.
Yeah, I would just add, again, goes back to what I talk about. If you have an excellent protocol, if you know you can get a triple rule out protocol and you perfected it in your institution, you have the readers that can efficiently evaluate those, a perfect test. If you have an institution that never performs triple rule out and your radiologists and cardiologists are not familiar with that test, don't do that test.
Can I ask a quick question at the end of Renee? Just as a leader, not only in cardiac CT, but multimodality, nuclear cardiology, how do you think the guidelines have changed your opinion on approaching chest pain?
Right, so I think, great question, Leslie. And I think one of the main things that we always have to think about is bringing it back to the patient, making it patient-centered. There's no, multimodality, do stress echo, stress nuclear CTs, but always bringing it back to the patient, because another patient may be more suitable for a nuclear stress test, such as someone who has had established CAD, who has had multivessel CAD, and then an ischemic guided approach with stress testing, particularly if you have stress PET at your institution, and even stress spec, but again, making sure that you have quality images. As I've told the whole staff here and my fellows, is that for nuclear stress testing, you have to have some way of attenuation correction. Even if you do not have the ability to have a solid state camera, you can do 2-position imaging. You must have some form of attenuation compensation so that we can minimize our false positive tests. But again, bring it back to the patient center. Thanks.
Great. Well, thank you very much. Excellent. Finish of this presentation and webinar as we have reached the top of the hour. So I think this is a very important moment. I'm not going to make jokes about Facebook. You never know who's listening. So, but I think in our little universe, I think this was a enormous moment and very important. These guidelines really represent both the state of the science, the state of the technology, and also how we approach patients with chest pain. And so a very important momentum that will guide providers for the coming years. So finally, I would like to thank everybody who spoke here. I mean, we heard excellent presentations. I want to thank all attendees for being here. I want to thank Siemens for their unrestricted educational grant that supported this, and our social media reporters who covered us in the other atmosphere. So please don't forget, next week we will be focusing on stable chest pain in these guidelines. And so that will be an excellent discussion again. So please come back, and hope to see you next week, same time, same place. Thanks, everyone.